Good evening, this is Keyshawn Goldmoss presenting on patient satisfaction and the quality of patient care. So we're going to discuss first of all finding the balance. Physicians are faced with the difficulty of managing providing what a patient wants versus what a patient actually needs. So UCLA Health System decided that they were going to discharge a patient to a rehab facility. However, the patient disagreed and refused to leave. After going back and forth, the physicians agreed to delay the patient's clinically appropriate discharge in an effort to keep the patient happy. According to Tony Padilla, which is the Director of Patient Affairs at UCLA Health System, providers are often inclined to give patients what they are asking for because the organization wants to have a positive experience or wants them to have a positive experience. So it's a perfect example of what physicians deal with on a daily basis in the healthcare environment. Patients present demands and healthcare providers must decide between giving the patient what he or she wants and giving him or her what is needed from a clinical and financial perspective. So when healthcare providers overshoot in an attempt to satisfy patient demands, they fail at doing what is in the patient's best interest. It was a costly lesson for UCLA. And what they realize is that it's for the patient's own benefit or in their best interest that physicians set boundaries. Now, overshooting. Overshooting occurs when clinicians allow patients to dictate some unneeded care that does not improve their health. It results in overtreatment, overprescribing, and increased spending. These are all direct results of a disproportionate focus on patient satisfaction. It's important to focus on patient satisfaction, but there has to be a healthy balance. Now, patient satisfaction measures. Patient satisfaction measures can be great, but they can come with some unintended consequences. And those include adverse impacts. They can also have a negative influence on value-based scoring systems or as a result of using value-based scoring systems, and also which can, of course, negatively impact Medicare payments. So these are some of the unintended consequences. So with adverse impacts, patient satisfaction efforts may be counterproductive to efforts to improve quality and patient outcomes or to control spiraling healthcare costs and healthcare spending. So with value-based scoring system, patient satisfaction responses, they generally make up about 30% of each hospital's score under the federal value-based purchasing system, which basically impacts Medicare payments because the score is responsible for increasing or decreasing hospitals' overall Medicare payments. I believe in 2013 it was by up to 1%. Now, the satisfaction in healthcare utilization. Do we please or do we not please? To please or not to please? That's the question. Do we go against the grain? And who's responsible for care coordination? So research documents basically that there is definitely a correlation between satisfaction and healthcare utilization. This link basically, so there is a link between patient satisfaction scores and increased healthcare services to clinicians, increasing desire to accede to requests or requested treatments to please the public and private payers, which have increasingly linked their reimbursements to patient satisfaction. So going against the grain. Clinicians have the responsibility to push for evidence-based standardized care as a way to improve overall clinical outcomes while lowering costs. This can be accomplished by placing patients in a care setting that's appropriate or is an appropriate form of treatment. And so, there will be times when you'll have patients that will not be satisfied and that will believe that such actions result in withholding of care. In those cases, it's important for providers to re-educate their patients on the available cost-effective treatment options rather than just going along with patient demands. And care coordination is another component. So care coordination is everyone's job. The emphasis must be on finding ways to keep patients out of expensive sites of care while still maintaining high levels of quality and patient satisfaction. Now let's talk about measurement. So HCAHPS, or the Hospital Consumer Assessment of Healthcare Providers and System Survey, is a tool that's used. We want to talk about that tool, but also we also like to discuss how accurate is it and should it still be used as a measurement tool. So HCAHPS basically asks discharged patients what occurred during their hospitalization, what type of treatment they received, what was their interaction with the physician. As of 2006, hospitals treating Medicare patients were required by the CMS to begin reporting survey results. Unpublished research from the Cleveland Clinic found that patients in poor health tended to give lower scores, which meant that facilities that care for high numbers of the sickest patients also had generally lower scores. A Modern Health, which is the organization that published the article that I'm presenting on today, they conducted a review of CMS patient satisfaction data. And they found that hospitals and provider groups with high marks showed only a modest improvement in at least one patient outcome measure, and that was the readmission rate. However, the research conducted and reviewed by the CMS indicated to its officials that the patient satisfaction and clinical outcomes generally correlate among hospitals that report on the agency's measures. Essentially, this means that hospitals and other groups that tend to score high on one tend to score higher on the other by a smaller amount. Now, CMS did decline to make any official statement or to have an official representative speak with Modern Health during its review, but it did unofficially state that some providers are seeing quality and patient experience indicators moving in opposite directions. Now, of course, industry-wide, it's a common practice to assume that by doing these kinds of measures and holding providers accountable to them, one will reduce costs and improve quality. CMS does acknowledge that there's no specific provision in HCAHPS that are designed to prevent overtreatment that drives up costs and ultimately can hurt the patient's health. So they basically leave it up to the hospital to determine how to best improve patient experience and to determine how to improve a quality of care. So now, what are some other measurement options? What are some other things that could be measured in HCAHPS that would provide greater insight? New surveys are currently under development by CMS that are focusing on patient communication with providers. That's one of the measurements. And that's one that I would recommend just right off the bat, is we need to evaluate, because a lot of times patients are dissatisfied because they feel neglected or unengaged or not like they're being made or invited to be participants at the table when discussing their health care. And so this is something that needs to be focused on. So researchers and providers alike cite a similar focus on measuring communication as one of the most cost-effective ways to use patient satisfaction to improve the quality of care delivered. So basically, if we communicate in a more patient-centered way, then we're going to have a higher batting average for getting compliance with patients and making them feel like they're a partner in their own care. Improving the staff's ability to communicate consistently, effectively, and empathetically with patients has absorbed basically the bulk of the estimated $1 million that UCLA health system had spent annually on improving patient satisfaction. So they're seeing the results. One thing that I wanted to talk about in this component is this measurement, this area of measurement also has the ability to influence physicians. So that's another reason why I think it's so important to address the communication. So Fenton suggests whether physicians undertook specific types of communication to better convey whether critical information was shared, such as asking whether the physician empathized with them. So that's something that can be measured. And really, it's going to also influence and encourage physicians to empathize. If they know that this is an area that they're going to be measured on, then of course it's going to be a focus point for them. So, if you ask a patient, did the doctor communicate well to you? Well, then you don't really get the details. You don't get down to the nitty-gritty. You miss the finer grains. Basically, whatever gets measured, that's what the doctor is going to pay attention to. So there's also a serious benefit to following up, and that's where the frequency of communication comes in. In addition to evaluating the types of communication used, patient satisfaction measurements should inquire about the frequency of interaction with providers during treatment. Some outside experts are pushing for improvements in HCAHPS and other patient satisfaction surveys to better capture nuances in the way different providers deliver care. So the HCAHPS survey's communication questions are currently limited to whether any dialogue occurred between the patient and provider, and not whether the patient's perspective was understood or whether it allowed them to share in decision-making regarding their care. So we believe that when designed and administered appropriately, patient experience surveys provide robust measures of quality, and our efforts to assess patient experiences should be redoubled. And that's a statement made by Glickman and his colleagues during their December 26 perspective in the New England Journal of Medicine. CMS patient satisfaction surveys could better meet the standard if they provided a better barometer of patient-provider communications, and I completely agree. Now, in application, how does this article apply? So, in my opinion, the most important takeaway from this article is to ensure that data measures are appropriate and relevant to ensure that the results are not skewed. I think that HCAHPS could be a more effective tool if it included the component of drilling down into the communication factor to determine patient satisfaction, and also then to encourage physicians to focus on communication as a driver to help increase patient satisfaction. So a Modern Health review on HCAHPS provides support that this is a good idea, and CMS's inclusion on focusing on communication as a component in its newer surveys points to the fact that HCAHPS may be missing an important measurement. I do think that this article is up to date and appropriate, and it's definitely a topic in the hospital that I work in. And I believe also that this article is useful in that it reminds the student and employee to ensure that the correct information is being evaluated when measuring data. It additionally encourages the healthcare providers to improve communication methods and frequency with patients to enhance patient care. And here's my references, which indicate the information regarding the article. And again, my name is Keyshawn Goldfuss, and it was a pleasure presenting on this topic of patient satisfaction and the quality of patient care. Thank you.